You may have been hearing the phrase trauma-informed care more and more lately. Recent years have seen a sharp increase in interest surrounding trauma-informed care and how to use it in practice. The Substance Abuse and Mental Health Services Administration, known as SAMHSA, formed the NCTIC, or the National Center for Trauma-Informed Care, in 2005. Since then, schools and organizations have started issuing certificates, trainings, and other programs meant to promote wider adoption of trauma-informed care practices. So you may have heard of trauma-informed care. It's a very important development in practice with many different types of clients. But do you really know what it is and how to use it? If not, this presentation will introduce you to some key knowledge related to trauma-informed care. And if this is not your first time to learn about recovery, but it's been a while since you reviewed the ideas, this presentation will be an excellent reminder of the concepts. In this training, you'll discover the symptoms of trauma, how we measure trauma, differences between the medical model of treatment and the recovery-oriented approach, and a real-world implementation of trauma-informed care. I'm Dr. Richard Hoefer from the University of Texas at Arlington's School of Social Work. With strong support from the Hogg Foundation for Mental Health, I'm presenting information to help you learn more about recovery and what the concepts of recovery are. The purpose of this training is to advance the goal of the Hogg Foundation Recovery to Practice grant program. We seek to enhance the implementation of recovery-oriented practice among behavioral health practitioners through participation in comprehensive, discipline-specific training, including for social workers. This information will be helpful to anyone interested in learning about the recovery approach to improving mental health services, whether they are still students or are experienced practitioners. People who experience trauma can react in a wide range of ways. These symptoms can be placed into three categories: intrusive recollection symptoms, avoidant or numbing symptoms, and hyperarousal. Intrusive recollection symptoms include persistently experiencing the event in thoughts, images, recollections, daydreams, and/or nightmares. This also includes feeling distressed or anxious in the presence of reminders of the traumatic event. Avoidance is just that, avoiding places, thoughts, conversations, or people associated with the event. People who have experienced trauma can also have problems recalling fragments of the event, or even the event as a whole. Other avoidant symptoms can include losing interest in formerly enjoyable and important activities of life, feeling disconnected or removed from other people, and feeling numb. The third category of symptoms, hyperarousal, is when a person is constantly alert for danger. This includes jumpiness, sleep disturbances, including insomnia, and vivid dreams or nightmares. Hyperarousal can also manifest as difficulty concentrating, anger, and irritability. Objectively measuring trauma is as difficult as one would expect. Traumatic experiences and the way they impact a person are as unique as fingerprints. Two people can live through the exact same traumatic event and be affected in completely different ways. So how do you measure trauma objectively? Is there a way to show trauma as a number on a scale? As it turns out, it is possible. The Adverse Childhood Experience Study, or the ACE study, was first conducted between 1995 and 1997. Participants were members of the Kaiser Permanente health plan who were already undergoing a comprehensive physical examination and chose to provide detailed information about their childhood experience. The large-scale study reached 17,000 participants. It's important to mention that the study's participants were mostly white, middle and upper class, college-educated San Diegans with good jobs and great health care. And the study may have had different results had it included a more diverse population. The ACE study asked 10 questions. Each question was worth 0 or 1 point, and the participant totaled points together to form their personal ACE score. The ACE score is used to assess the total amount of stress experienced during one's childhood. Here are the questions from the ACE test. If you want to pause and look it over or take it yourself, you'll see one question at a time, then the video will go on to the next. Feel free to pause the video to answer each question, then total it. Question 1. Did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? Question 2. Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Question 3. Did an adult or person at least 5 years older than you ever touch or fondle you, or have you touched their body in a sexual way, or attempt to actually have oral, anal, or vaginal intercourse with you? 4. Did you often or very often feel that no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? Question 5. Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, and had no one to protect you? Or your parents were too drunk or high to take care of you or take you to the doctor if you needed? 6. Were your parents ever separated or divorced? 7. Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her? Or sometimes, often, or very often kicked, bitten, hit with a fist, or hit with something hard? Or ever repeatedly hit over at least a few minutes, or threatened with a gun or knife? 8. Did you live with anyone who was a problem drinker or alcoholic, or used street drugs? 9. Was a household member depressed or mentally ill, or did a household member attempt suicide? Finally, did a household member go to prison? So I want you to total yes, the number of yes answers, and this is your ACE score. The ACE study found adverse childhood experiences of abuse, neglect, and family dysfunction to be common. Almost 2/3 of study participants reported at least one ACE, and about 20% reported a score of 3 or more. A person's ACE score can help explain their risk for health and social difficulties. As your ACE score increases, so does the risk of disease, social, and emotional problems. The study found that for those with a score of 4 or more, the likelihood of chronic pulmonary lung disease, hepatitis, depression, and suicide increased significantly. The ACE study has been conducted multiple times in over 36 states with similar results, increasing its validity. As we can see, as the ACE score increases, physical and mental health problems increase, creating negative short and long-term outcomes. The pre-recovery or medical model mindset is to ask, what's wrong with you? Or rather, what's wrong with you? In this approach, symptoms are counted, diagnosed, and then medicated. In this model of treatment, a power dynamic is present. There are many ways in which power can be used or misused, but people often take on 3 distinct power roles. There's the victim role. This person believes he or she cannot take care of himself or herself, and thus has a sense of powerlessness. There's also the persecutor. This person believes people need to be coerced or controlled. There's also the rescuer, who believes other people cannot take care of themselves. These roles are normally outside of our conscious awareness, but can contribute to a feeling of powerlessness or loss of agency on the part of the person being treated. In the medical model approach, we often overlook asking, "What happened to you?" which is core to the recovery model. By treating people as experts on their lived experience and equals in the treatment process, we seek to level the power dynamic and help them live their lives more fully. In the recovery model, staff people are seen as listeners, supporters, and enablers of the person in distress. They treat people as experts in their lived experiences and equals in the treatment process. Staff may also conduct some assessment, but the goal for recovery practitioners is to assist the people in distress to recover their sense of agency and self-determination, not just to diagnose them. People in recovery are assisted to engage in their world, take positive action, and regain optimism and agency. Let's turn now to an example of the trauma-informed care and recovery model in action. Fall Hamilton Elementary School is an example of trauma-informed care being implemented in a practical, everyday setting. According to the principal, the old approach was compliance-driven, and the new approach made an effort to focus on student safety and support. The school focused on educating the faculty on trauma-informed care first. They implemented a social and emotional learning curriculum, as well as mindfulness practices, softer lighting, and better teacher support. The faculty focused on building strong relationships with students, including implementing a check-in, check-out program, where students are assigned a mentor who talks to them at the beginning and end of every school day. The program allows the student and mentor to discuss goals and difficulties for the day. But most of all, it provides a stable, supportive mentor relationship. According to the school principal, the most motivating piece of our check-in and check-out system is the mentor-mentee relationship. The child knows every day that they come into this building that someone is excited to see them in the morning and excited to see them right before they leave. After the implementation of these changes at Fall Hamilton Elementary, the school saw a decrease in behavior infractions. Trauma-informed care focuses on restoring a sense of safety, power, and self-worth to an individual adversely affected by trauma. Trauma-informed care promotes earning trust, embracing diversity, providing holistic care, respecting human rights, focusing on a person's strengths, sharing power, and having communication with compassion. As we saw in the Fall Hamilton Elementary example, trauma-informed care is demonstrated within agencies through policies, procedures, and practices that emphasize individual safety, as well as recognizing and restoring power to individuals. And as you know from our previous presentations on recovery, these principles of trauma-informed care are compatible with the principles of a recovery-oriented model. The goals of the recovery approach are hope, safety, calm, self-efficacy, and connection. Mental disorders are considered lifelong conditions requiring ongoing psychiatric intervention and/or medication. However, long-term recovery among those diagnosed with a mental disorder is relatively common. Trauma-informed care practices help set an individual on the path of recovery by evaluating past traumatic events and present symptoms to create a more holistic and accurate diagnosis and treatment plan. In the next video, you'll learn about secondary trauma and your risk as a peer support figure. You'll be provided with a basic understanding of secondary trauma, how to identify warning signs, and what to do if you believe it has happened to you. For more information in the Fall Hamilton Elementary School example, watch the 8-minute video, Fall Hamilton Elementary Implements Trauma-Informed Care, available on YouTube at this address. It's well worth the time. It's only about 8 minutes long, and you'll learn a lot more detail than what I was able to share with you.